Okay, so guys, I welcome one and all to this class in which we'll be discussing about menopause, a very, very important chapter when it comes to DNB theory. Practicals, I don't know how much emphasis will be given on menopause, if they can keep a menopausal women in the, ward rounds, or they can, put the menopausal women for one of your major case. You had it because it's very difficult, to present a case on that. Usually, we have not seen any, but you never know DNB people. So what exactly is menopause? See, it's a retrospective diagnosis. Let me tell you that, okay? So there'll be people who will come to you with all varied permutation and combinations. I'm sure all of you have handled it in the OPD, okay? Light periods, long duration between the long gap in between the periods, okay? Frequent periods, scanty periods, heavy periods. So all permutation and combinations you'll get when the patient is nearing menopause. Until you get an amenorrhea for consecutive 1 year, 12 consecutive cycles, you can't call it as a menopause. So it's a retrospective diagnosis. Goes back in time. At that point in time, it's very difficult to say whether it's physiological or some pathology is involved. So it's defined as a time when ovary cease the functioning. That means the periods are stopping because of the decrease in function of the ovaries. Then it's a menopause. Some other reason, that's not the answer. So premature ovarian insufficiency will be premature menopause. It's not physiological. This thing which we're talking about over here is menopause. That is physiological. So the menstrual period stops, marking the end of reproductive years. It's a retrospective diagnosis when the woman stops monthly period for 12 consecutive cycles. The age of menopause is around 48.5 plus minus 2 years. And obviously, this is from an Indian book, not from the foreign authors' books like your Novaks. Now we come to a phase called as perimenopause or climacteric, which is actually that time when you start having these changes. Okay, so you're having a menopause, let's say at the age of 48, but the changes, they start happening at the age of 40 years or 41 years or 42 years. So the menopausal transition happens to be the time preceding the menopause, which is characterized by irregularities. There's so many, like I just told you, your OPD is full of such patients who come to you with these erratic cycles, irregularity of menstrual cycles, missed periods, and that can extend up to 1 year after the cessation of menstruation, along with a moderately raised FSH. So you have to just go ahead and do certain hormonal assays to find out what is wrong. Okay, so TSH, prolactin, even FSH in females who are coming to you with 2-3 missed cycles and then suddenly a very heavy cycle, go ahead and do FSH. Half the things will be clear to you. So FSH usually is raised above 20 international units per ml. And this perimenopause, it's a very vast time period, so 4 to 7 years also it can, present to you. And the reason is that over here you have a depletion of oocytes. So slightly, slowly, the ovarian reserve is declining and the function is dwindling. You are having anovulatory cycles. Very, very important. Now, let me tell you guys that you had a lot of, part in all the books is about the, menopausal changes, menopausal symptoms. A lot of weightage is there. Okay. So this question can be easily expected in the examination, that write a short note on the menopausal changes. Now, it can be, it can come in different dimensions. I'm talking right now about anatomical changes, but the question can come for cognitive changes, vasomotor symptoms. Genitourinary syndrome is a very, very important question. So symptoms of menopause, a lot of questions can be framed. Why so? Because so much weightage is given in your Novaks on just the menopausal symptoms. So let me just quickly go through it, because this is this part, anatomical changes, you can write even without reading also. So why waste time in certain thing which you can easily write either ways also? Remember always this thing. A thing which you don't know even one sentence about, read that. Thing which you can write at least something, you can skip it when you have scarcity of time. Right now, there is a lot to be covered, important things to be covered in menopause. So I'll just try to, kind of rush through this. So what do you expect in ovaries? Actual changes happening in the ovaries only. The ovaries are the one because of which you are having these menopausal changes. So what happens? They become shrunken, they become smaller, their size becomes small, and any enlarged ovary at this point in time has to be taken very, very seriously, has to be investigated for ovarian cancer. Fallopian tube becomes smaller, atrophic muscularis, atrophy. So you'll hear these two words. Becomes small and atrophic. Becomes small and atrophic. So see this. Uterus becomes small and atrophic, atrophy of myometrium. Okay, endometrium becomes atrophic. So you will get to hear these words again. Cervix shrinks in size, and now here very important thing happens is that earlier on the ratio of uterus to cervix was 2:1 or 3:1, but in menopause it becomes 1:1. Very important. Sometimes this question is asked as MCQs in many of your competitive examinations. Vagina, I'll take up very seriously over here. I've marked it in blue. Why? Because just read it through. Because your genitourinary syndrome is a part of all this. So because of lack of estrogenization, vaginal mucosa becomes very thin, pale, dry, narrowed down. So have you seen difficulty in taking pap smear of a patient who comes to you at menopause? The reason is because it's so dry. Even if you're doing a very gentle, per vaginal examination or very gentle introduction of the speculum, patient is, jumping on the bed, very uncomfortable. Reason is that's so dry. The passage of, anything, any speculum or even your gloved finger irritates them. So it's because of this pale, thin, dry, narrowed vagina, it gets stenosed. Okay. It becomes more prone to infection, more prone to, dryness, itching. And here starts, this is the basis of genitourinary syndrome asked many times in your DNB theory examination. So you have recurrent vaginal infection. That's one thing. Dryness and itching is all the time there. Very important factor in having sexual dysfunction. Very important. Okay, coital problems. Dyspareunia, very, very common because of this. And obviously a lot of urinary tract infections because of this dryness over there. Vulva becomes atrophic, labia majora and minora, they lose fat. Urethral mucosa sometimes plus urethral caruncle, which you can see over here. Can you see urethral caruncle? I just mention it because this is a very important feature of the menopausal age. That's also a question asked many times. So the breast, they become more shrunken, become more pendulous, but a lump, secretion, tethering, of the breast has to be taken again very seriously. Why? Because all these are features of breast carcinoma. Then skin wrinkled, hair becomes gray, okay, bones and joints become brittle, there is lack of estrogen. So actually it's the lack of estrogen which is causing all these symptoms. So I hope anatomical changes you can write down. Now, Straw 2011. I'm quoting this study because just in case a short note is asked on Straw 2011, you should not be zapped what to write. See, this is very important. You should know a little bit about everything, a little bit, something about everything. Why? Because any answer left blank is very dangerous in theory examination. You know the pass percentage in theory, so why to take chance? So a little bit you should know. And with my class, this is my aim to give emphasis on those things which you do not know anything about, so that something stays in your mind with my class. So though it's a very old, see, it's 2011, it's 2023 going on. DNB people have a habit of asking questions which are just recent, but you never know what examiner is sitting to make the exam, to kind of frame the questions. So anyways, a little bit about Straw 2011. Straw is nothing but stages of reproductive aging workshop. Stages of reproductive aging workshop. Menopause, Straw menopause. Okay, what it has done is that it has divided the entire life of the woman into 3 phases. What are those 3 phases? I've marked it over here. Reproductive, menstrual transition. Sorry, reproductive, that means normal menses is going on. You're not even close to perimenopause. This is menstrual transition is perimenopause, and then comes postmenopause. Amongst which you have early, peak, late. Early, peak, late features. What are they? In which the principal criteria is menstruation. Because you are not going on FSH, you're not going on inhibin, you're not going on estrogen, you're not going on any endocrinal dysfunction or antral follicle count. What's most important to you to label any female with menopause is the menses. So that becomes the principal criteria. Reproductive life, you have variable kind of menstrual cycle in everybody, but mostly regular. Right? Around the time when you have menstrual transition, it becomes subtle changes in flow length, subtle changes in the in the flow and the length of the periods, and the gap as well. And then variable length, sometimes persistent. Then more than 7 days difference in the length of consecutive cycles. Then comes amenorrhea. Sometimes amenorrhea is for 2-3 months and then heavy cycle. Then becomes 5-6 months and then heavy cycle, and then starts a period of amenorrhea. So all varied combinations are there in this particular phase, which is called as the menstrual transition or the perimenopause. What about postmenopause? It's usually pretty stable. There is no menses. Okay, so you don't have to tell me what are the specific principal criteria of calling it a menopausal stage. 12 consecutive cycles with amenorrhea. Supportive criteria. You have all the hormones you can think of: FSH, AMH, inhibin, and the antral follicle count. They are supportive criteria which will, kind of associate a patient who's undergoing this menopause with, this criteria that yes, they are also raised. Patient is also not having periods. That means most probably going towards menopause. And then certain descriptive characteristics like symptoms. Patient is having hot flushes. Okay, patient is having some cognitive mood disorders. So these are all supportive symptoms. Then, so that was STRAW 2011. Now I'm giving you a brief tour as to what. See, right now I'm starting to discuss the symptoms of menopause. What's going on in the menopause? Okay, so how important it is. There are, I think, 5-6 slides on this alone. Impact of estrogen deficiency and how it causes, various disorders, which are all symptoms of menopause. So there are certain early symptoms, there are certain late changes, and there are certain later disease. Do you know the later disease is the most dangerous? Osteoporosis, cardiovascular disorders, dementias, cancers. They're all different features of estrogen deficiency, but years after menopause. Okay. Late physical changes like, immediately the patient, when the estrogen deficiency is there, what happens immediately to a patient? Starts having hot flushes. This is called vasomotor syndrome. So hot flushes, insomnia, irritability, mood disturbances. These are the things which happen immediately, within weeks of menopause. Later on, maybe after a couple of months to years, you have this sexual dysfunction because of dryness, itching, stress urinary incontinence, connective tissue changes because of which, this genitourinary syndrome. So this was vasomotor, genitourinary, and then later on multiple disorders like cancer and osteoporosis and CVD. Now, what is the physiology? This was also a question asked. Endocrinological changes causing menopause. So how do you like this slide, guys? Would you like to read this? And what about this slide? So I would love to read something like this. If you write something like this in the examination, you've increased my burden of checking the paper. Okay, I will not like a student like this. I will like a student like this. But remember one thing, a short form should not be that short that the examiner has to, put more brain into understanding what you have written rather than maybe going through this slide. Okay, so, okay, oocyte number decreases with age. Okay, because of atresia, because of apoptosis, because of aging, what's happening is the oocyte number is decreasing. And by late 30s or early 40s, ovaries start becoming devoid of follicles, which is the reason why IVF becomes a little more difficult with patients in their late 30s, early 40s. So because of this decrease in follicles, because of a decrease in the AMH hormone, estrogen and inhibin also start decreasing. Okay, there is a decreased production from the granulosa cell of estrogen and inhibin. And that finally inhibits the inhibitory feedback. Sorry, that causes an inhibitory feedback. What happens is that, you've got less of estrogen, less of inhibin. So it's giving a negative feedback to the hypothalamus and to the pituitary. So suddenly they realize, oh my God, we need to increase the work. There's no estrogen at all in the body. So GnRH increases, FSH and LH also increase. Okay, which is the, hormonal changes that you will find during menopause. One very important thing which the examiner wants to know over here is that the estrogen milieu that changes. Okay, so there is a reversal of E2 is to E1 ratio. Now, what is E2 in E1? E2 is estradiol, the 80 times potent estrogen. Okay, estradiol, more potent than estriol, far more potent than estron. Estron is the most abundant or predominant estrogen of menopause. And it is called as a very weak estrogen. Okay, but in menopause, you'll find it in an abundance. So the examiner also wants to hear this from you. So what happens? What are the hormonal changes that take place? So you have to speak about that, estradiol, usually what is the ratio? 2 is to 3 is to 1. That's the potency. Most important is estradiol, then comes estriol, then comes estron. Estradiol, estriol, estron. Repeat after me. Estradiol, estriol, and then estron. But what happens in case of menopause? That estron suddenly becomes the predominant hormone. And the most potent hormone is somehow washed off, cleaned. It's not in par right now. Also, LH and FSH have increased 4-folds at the time of menopause, okay? And because you have an ovulatory cycle, there is no progesterone production. So there are so many hormones I've spoken about. I've spoken about FSH, I've spoken about LH, I've spoken about AMH, I've spoken about estrogen, I've spoken about inhibin, and now I'm talking about progesterone. So ovarian stroma is still producing some estrogens, some androgens. Adrenals are producing androgens, okay? I just took a class on adrenal hormones, so you do know that androgens are produced. Okay. These androgens are converted to weak estrogen, estrone, okay, which is in the peripheral adipose tissue, especially in obese. So what happens in the obese patient in whom we have a, the scare of breast carcinoma, endometrial carcinoma. In them, this conversion of, adipose tissue androgen to estrone continues because the adipose tissue is right there, okay? So this continuous conversion keeps taking place. So there is always a no estrogen deficient environment in a obese patient, even in menopause. Okay, no matter how weak the estrogen is. So you should know that as well. Again, see, like I said, so many slides on just the symptoms alone. So immediate effects are, like I said before, menstrual symptoms, most important, vasomotor symptoms, the mood disturbances, cognitive dysfunction, sexual dysfunction, which comes, immediately. The moment occur in menopausal transition, early parts of menopause. Within weeks to months, these symptoms are going to come. Not just this alone. Headache, dizziness, palpitation, breast engorgement, bone and joint pain, even urinary incontinence sometimes, dysuria, frequency, not stress, but frequency, yes. And then there are intermediate effects. Occurs after a few years, I would say months to years after menopause has set in, like genital atrophy, Now comes a urinary tract atrophy causing, urinary incontinence, the stress urinary incontinence. See, if it's too itchy, that area, the detrusor muscle becomes more stressed, okay, because of this continuous irritation in it. So you have what is called as OAP, overactive bladder. Not exactly the stress urinary incontinence, but also this overactive bladder syndrome. So you have to be very sure when you're dealing with a patient, whether it is stress urinary incontinence or overactive bladder. Okay. Prolapse, yes. Dry, itchy skin. And then, of course, a delayed dangerous signs which take place, long-term effects like osteoporosis, cardiovascular defects, CNS effects, and then, of course, all kinds of cancers which can take place. So then comes this Kupperman score. Again, one thing which I can ask as an examiner, to assess how much the students are studying, how much they know the complete thing about any chapter that they are doing. So Kupperman score, they love to ask you these, scores, different terminologies, different studies. One of the favorite questions. Though this time the paper was pretty good, but we'll talk about it later. So Kupperman score is actually now very important, is that it's based on psychophysiological symptoms. Okay? It's taking into account, see what all it's taking. Sweating and hot flashes, paresthesias, insomnia, nervousness, melancholia, feeling of doom, vertigo, fatigue, arthralgia, myalgia. These are all subjective. These are all subjective symptoms. If you've been to this menopausal clinics, we had menopausal clinic from a very long time in our hospital. If you ask this patient who's come to you, do you feel tired all the time? She'll say yes. Do you feel irritable? Yes. They are so happy to describe these symptoms to somebody. At least somebody is listening. Most of the females, they have this lack of empathy at home. So when they do get to, kind of voice it out to people who understand, they say yes to all the symptoms you ask them. Then comes the severity. So that symptom is definitely there. What is the severity? Is it not there? 0. Is it sometimes, once in a while, you're feeling you did not sleep properly at night. You're having, this muscle cramps or arthralgia, or you had a headache once in a while, or frequently does it happen? So there's a severity scale of 2, or it's affecting your lifestyle. So nobody is asking you to draw this, table. The same thing I'd like to say for STRAW 2011 as well. You don't have to ratify and remember and put it. As examiners, even we will not remember what it was, which scoring was given where. but we would definitely like to know whether you have an idea of what is asked or not. So even if you write that modified Kaplan index is based on psychosocial symptoms and you don't even write these symptoms, you write something else, maybe instead of paresthesia, you write numbness. Okay. Insomnia, you write, disturbed sleep, mood swings. Okay. I will give you marks because it's based on all subjective symptoms mostly. Okay. Which you can ask the patient, they'll say, and you have to believe it. Right? So that was Kaplan score, and mind you, a very important part in understanding menopausal females goes on to this. And very important thing that we have a huge burden of around 80 million people who are living with menopause currently.